All right, well, good afternoon and welcome everyone to this NBCC lead webinar with our featured presenter, who's not new to us. He's been with us several times, Dr. Bishal Gayawali. My name is Michelle Tregear and I'm the Chief Programs Officer at NBCC, and we're pleased that you could join us today. So as a project lead trained research advocate, it's critically important that we continue to hone our critical appraisal skills. We need to be careful consumers of clinical trial literature, and we need to be able to spot biases and other problems in the clinical trial research that comes out and we're constantly hearing about. But we also need to be able to spot signs of good quality research. And so this webinar is a follow-on to others in our critical appraisal webinar series, where our goal is really to help you all gain the skills that you need to be able to understand and interpret and critically appraise the results of clinical trials that you're hearing about, or when you're reviewing clinical trial protocols, or even doing grant peer review. And if you like this content, we have a number of other training activities, for instance, our learning management system that are available to you, so that if you're interested in taking advantage of this learning, you're more than welcome to. And I'd like to just say thank you to all of you for being current members of NBCC, because it's that support that really is important in allowing us to continue to bring you this ongoing training. So just a few reminders. Today's webinar is being recorded and a link will be available after the presentation. You have all been automatically muted so that we can limit background noise and have a good quality presentation. Dr. Gayawali will present for the first portion of the webinar, and then we will use the remaining time for Q&A. But I really highly recommend that you submit any questions that you have using the Q&A panel as they come to you, and then we will get to as many questions as we can following the presentation. So without further ado, let me introduce our speaker. Dr. Bishal Gayawali is an associate professor in medical oncology and public health service sciences, and a scientist in the Division of Cancer Care and Epidemiology at Queen's University, Kingston, Ontario. His research interests include cancer policy, evidence-based oncology, financial toxicity, clinical trial methods, supportive care, and global oncology. And as I think many of you know, he is an advocate of the cancer ground shot, which is a term that he coined to imply that investments should be made on proven high-value interventions in cancer care that are easy to implement globally and that are affordable. Dr. Gayawali was also the recipient of the 2020 ASCO Conquer Cancer Foundation Global Oncology Young Investigator Award in Implementation Science. And he was also awarded the Young Health Researcher Award in 2020 by the government of Nepal. Dr. Gayawali is also very active in oncology and clinical research communities on Twitter. And if you are on Twitter, I highly recommend that you follow him at oncology_BG. So with that, I'm going to turn it over to Dr. Gayawali. So let me take down my slide here and pass it over to you.
Yeah, thank you. Thank you very much, Dr. Tregear, for this kind introduction. Yeah, it's always a big pleasure for me to speak with the NBCC group. I have spoken to the NBCC group before as well. And as I keep saying, one of the changes that I want to see in the oncology domain is that I want to see more and more patients getting involved in the clinical trial design, in clinical trial interpretation, in the use of clinical trials. As Michelle mentioned, we may not be creators of cancer research, but we are consumers of cancer research, and it's ultimately the patients for whom it matters the most about what the clinical trial outcomes are. So I try to make it a point to be able to speak with the patients, speak with the patient advocates as much as I can, and try to do my part to help improve understanding of some of the important aspects of appraising a clinical trial literature well. And so I'm happy to be back here again. And interestingly, I think it will be of interest to the participants of this program that Michelle and I have become co-authors on a paper now on a Lancet Oncology publication about what progression-free survival actually means. And we advocate for a change in the name of progression-free survival. So just a side note that might be of interest to the audience. So anyways, today's title of my talk is, what should you look out for when reading a clinical trial report? So you have a clinical trial report that you want to read for your own reasons, but what are the biases that can creep in? What are the things that you should look out for? What are the things that need a deeper dive? And what are the things that you can trust? So I'll try to highlight some of those aspects today. I have no conflicts of interest that are relevant to this talk. So just let's take a sample. You came across this paper, atezolizumab and nab-paclitaxel in advanced triple-negative breast cancer. And you want to know whether or not to, what are the results of this trial and what are the conclusions of this trial? What is the take-home message? So you have this paper in front of you. So what do? Let's start with that. So the first thing you notice in any paper is that it starts with an abstract. So the first question is, do you read the abstract first? When do you read the abstract? So I'd like to give an example. This is a news article in Twitter I saw, and this news said, a Pakistan cricketer Mohammad Irfan confirms he's alive after death. This surprised me. How can someone become alive after death? And this news seemed very interesting. So I clicked on it. I wanted to know, how can someone confirm that they're alive after death? And when I clicked on this, this was the full news. Pakistan cricketer Mohammad Irfan confirms he's alive after death hoax circulates. So it's not that he died, but there was a rumor about his death. So this is an example of why, like, I don't want to read abstract. And I want to go directly into the paper, because this on the left side, this is like reading an abstract. It can be misleading. There will be several details that have been missed in the abstract. We routinely see in cancer drug trial publications that the side effects are not reported in the abstract, quality of life information are not reported in the abstract, and some of the other key findings are not reported in the abstract, and there is substantial bias in the reporting of abstract. So if you do not have access to the full paper, then you have to read the abstract, I guess. But as long as you have access to the full paper, I think you should just skip the abstract. There is no reason to read the abstract. Okay, we discussed that we are not going to read the abstract, but what are the other things that we need to take care of before we start reading the paper? I think there are a couple of things that we need to note even before we start reading the paper, because the answers to these questions will have implications on how we read and interpret what is being written in the paper. The first is, who funded and sponsored the trial? Who conducted this trial? Who has a financial stake in the trial? And the other is the conflicts of interest. Are the authors who are writing this paper, do they have conflicts of interest, or are they independent? And this is bizarre, but who wrote the paper? Because you would think that the authors wrote the paper, but in many new recent cancer drug publications, you'll see that a paid entity, what we call medical writers. There are medical writers who write the paper for the authors after getting paid by the industry. So, for example, in that previous publication, so where do you find this information? One, you find it at the end of the abstract, but this will also depend on journals. This is what New England Journal does. JCO has a different system. Lancet has a different system. But here it says this was funded by Hoffman, LaRose, Genentech. And you can also see the same thing in the methods. In the methods, they mention the trial sponsor, which is the Genentech, who is the manufacturer of atezolizumab. And then they also mentioned that Celgene, who produces nab-paclitaxel, they provided the drug, but they did not have any role in the trial design. However, Genentech, who makes atezolizumab, they collaborated regarding the trial design and data collection, analysis, and interpretation. This is a red flag sign for me. Like the sponsors, they can obviously collaborate for trial design, data collection, analysis, but the interpretation part, I think it should be independent. Interpretation is interpretation of the results. The industry, who has a financial stake in the outcomes, should not be the one who is interpreting the results. So that is a red flag sign. And then it also mentions that all the drafts of the manuscript were prepared by the authors with editorial assistance from professional medical writers funded by the sponsor. So yeah, there were professional medical writers involved in writing this manuscript. Now you might think, why would we need a professional medical writer to write a clinical trial report? The authors, the trialists, they can themselves write it. But when you read the paper, you'll see some signs of why professional medical writers are needed, because they know how to bias the results. They know how to twist the results in a language that is deceptive, but may not be very easy to spot. And the other thing is the authorship team itself. So if you look at the authors, there are 2 authors in this trial publication who belong to Ross, who belong to the company. So these are like, there are people in the authorship team itself who are from the company. So obviously they will have a huge influence and bias in how to write the results and how to shape the interpretation. One more example. This is from the Olympiad trial. Again, it says funded by AstraZeneca. That makes olaparib. And then again, in the authorship team, you can see that Dr. Wu being employed by and holding equity and other ownership interest in AstraZeneca, like they are being employed by the company. These are employers of the company who are in the authorship team. This is not just doctors having some financial conflicts, but they're actually being employed by that company. So the employees of that company are writing the paper, of course, in collaboration with other medical doctors and trialists. But if you look at this conflict of interest disclosure, you'll see that everyone has had received financial payments from the exact same company, AstraZeneca, whose drug is being discussed here. So this should give us some pause about, this does not necessarily mean that there is something bad going on, but this is a big red flag sign, and we should be very careful not to trust, not to take things at their face value. We should always keep in mind that, okay, this is being written by professional medical writers who are being paid by the company. The authorship team includes people who are employees of the company. Other authorship team includes doctors who are getting financial compensation from the same company. So whatever they are writing here, is it actually right, or should we take it with a grain of salt? That's something we need to keep in mind all the time. And again, if you go into the trial oversight trial oversight section, you'll see that you'll see the role of the company. And as long as the company is involved in collection and design and analysis, there are no problems in my end, in my opinion. But if you see this interpretation section, then that makes me very uncomfortable. The interpretation part should belong to the actual physicians who did the trial, or the other physicians. It should not belong to the company. Again, this was written with medical writing support, which is funded by the company. Okay, so we discussed about the conflict of interest and the funding part, who wrote the paper. One more thing before going into the other issues in the trials, trial conclusions. What about the trial conclusion? You'll see a section called conclusion at the end, even in the abstract and in the main paper. The conclusion section provides the most important take-home message from the trial. So do you read trial conclusion? How do you read trial conclusion? When do you read trial conclusion? Again, I'll give you an example. This is a real news that I found. This says a pair of glasses were left on the floor at a museum and everyone mistook it for art. So what this means is, if you have certain bias, then you can draw any conclusion that fits your bias from whatever data you are seeing. So that means if you have a bias to consider the trial as positive, then even if the results are clearly negative, you will find something in there to say that it is positive. And you'll conclude that this is a good treatment, this is a good drug, and everyone should be using it. Even if the drug is not good, even if the results are not satisfactory, you can draw that conclusion. You might find some subgroup analysis, you might find some tiny positive findings within the bigger picture, and you might highlight that. So trial conclusions are like that. We should be very careful. For example, I'll give you an example. This is a trial of olaparib versus placebo. So here the conclusion, if you read, it says, although the hazard ratio for overall survival was in favor of maintenance olaparib, there was no statistically significant difference. So that there was no statistically significant difference means that the survival did not improve. The survival had not improved. But the way they are writing it, and this is a telltale sign of the medical writer writing it, is that it says, although the hazard ratio was in favor, so they start with the hazard ratio was in favor, but then they say there was no statistically significant difference. So that means that actually the survival had not improved. And then they come up with a different endpoint. This is not even PFS, this is PFS2. And then they say PFS2 showed a clear trend. And now look at this language. PFS2 is a very bad surrogate endpoint. We'll talk about surrogate endpoints, but this is not even PFS. This is PFS2, which has no validation whatsoever. And then they highlight PFS2. They say PFS2 showed a clear trend for treatment benefit in favor of the drug, but was not alpha protected. So that means they ran multiple hypotheses. This was not significant. And again, this was even that PFS2 was not significant, but they are highlighting a trend. So this is one of the most biased, bizarre conclusions that I have read in a trial publication. But it has become more or less the norm nowadays. So I think I also saw a Q&A question here. I'll try to answer it right now. It's about the peer review process. So we can't trust the peer review process. These are all publications that are published in the topmost journals in the world. And this is the language that is appearing in these top journals. So it clearly shows that we cannot trust the peer review process, because the peer reviewers will also have conflicts, financial or otherwise. Sometimes it's like, if you look into a tiny tumor subgroup, then you will find that it's always the same 5 or 6 people in the world who are the first and the last authors of all these trials in that given tumor cohort. So when 2 of these people are authors in a trial, the other 2 or 3 will become the peer reviewers, and they know that in the future they are going to be the authors and vice versa. So it's like a mutual society where everyone accepts each other's work and congratulates each other and says, we are doing a wonderful job. So no, we cannot trust the peer review process. And that's why we need to have better critical appraisal skills. And we're talking about experts. So I would say be aware of experts. Because experts are not necessarily people who have the expertise. In this era of media, your personal campaigning, in this era of social media, where what everyone wants is just 100 more followers for their social media account. It's nowadays, experts are people who show up on TV, experts are people who show up on social media, experts are people whose tweets get retweeted millions times. These are the people who we consider to be experts. and not necessarily because they have an expertise. Like you see in this example, these are like very funny and you might think these are like extraordinary examples, but this has become a norm, I would say. And in fact, we published a paper a couple of years ago about people who write editorials in these topmost journals, in New England Journal of Medicine, in Lancet Oncology, in JAMA, in JCO, people who write editorials about the trials that are published in those journals. And we found that there is a huge bias in terms of the editorials who are getting funding, financial payment from the same company whose drug is being discussed, and them writing a favorable editorial. So there are two problems here. One is that these journals are asking people who have received financial compensation from the exact same company to write an editorial on the same company's drug. That is a problem in itself. And these are the people who will have done peer review for this drug. And the second problem is there was clear favoritism, like these editorials were writing favorable things about the cancer drugs in the editorials, and not favorable because the trials were good, but this is unduly favorable editorials. Even when the trial failed, they were saying positive things about the drug, for example. And that also brings to the opposite end of the spectrum, where the real experts sometimes can be drowned by the noise of the social media nowadays, and that's a real harm. Because this is a fun cartoon that shows that if Galileo was our contemporary and he would have said that the earth revolves around the sun on Twitter, then it would come with a notification that this claim is disputed by theology experts. This is a fun cartoon, but this is not too far away from the truth, I would say. The real experts, if they point out some issues, it can easily be drowned out by the noise of the social media or other people who have stakes in the game. Okay, now let's delve into the proper agenda for today. What are the key issues to look out for when reading a clinical trial publication? Okay, the first thing that we need to look out for is whether it's a randomized trial or a single-arm trial. I think randomization is one of the best things that happen to medical science, because the question that needs answering for every medical decision making is, what if I don't do this? A physician says, let's do this. And the question would be, what is the counterfactual? Like, what happens if I don't do this? Now, when we are doing trials, we cannot obviously do both the things on the same person. Like, we cannot give a medication for that person, and we cannot also not give medication for the same person at the same time and see what will be the differences in outcomes. But the best thing close to that is doing a randomized trial where we randomly select people and give medication to half of them and don't give medication to the other half, and see what happens to the outcomes on average. Are they different? That's the best we can do. So the question that needs answering is, what would happen if not for the intervention? And that question can only be answered from randomized trials. Yes, single-arm trials, real-world evidence, everything has its own merit, but that particular question can be answered only by randomized trials. What happens in a counterfactual world, in a parallel universe where everything is same except for that intervention? The problem with single-arm trials is we don't know what happens in the counterfactual world. We don't know what happens if we don't give the treatment. And the other problem is, when we are running a single-arm trial, we know that we're going to give the drug and we want to see the outcome. So we are biased in selecting the patients for our trial. We are not selecting our normal patients. We are selecting highly selected patients who we believe can tolerate this new drug very well and will have very good outcomes. So it's a biased population. These single-arm trials are not powered, and there is no good criteria for success. For example, you'll see like several of these drugs approved on the basis of single-arm trials and response rate. You'll see that there is a drug that gets approved on the basis of a response rate of 20%. Another drug, 25%. There is another drug with only 18% response rate also gets approved. So what is the benchmark for success? What percentage of response rate are we going to consider success? We don't know that. And single-arm trials, they're actually not meant to inform practice. Single-arm trials are meant to inform phase 3 trials. If a drug is so bad that we are disappointed with even a phase 2 single arm result, then we will not take it to a randomized trial. And the other problem is that in single arm trials, we see that these responses and duration of response, they are falsely exaggerated. They are not the true responses. We had done this analysis a couple of years ago about failed or negative phase 3 cancer drug trials. We wanted to see why are these cancer drugs failing at phase 3, because we obviously want to avoid that. We want phase 3 trials to be successful. And we found that among those negative phase 3 trials, 42% of them, they did not have any phase 2 trial evidence. So there was no phase 2. People who were directly doing phase 3. But most importantly, nearly 14% of negative phase 3 trials were conducted despite a negative phase 2. So people were doing phase 2 and the drug failed in a phase 2, and still we went on to do a phase 3 from the same drug. So this is almost like doing a phase 2 and seeing if the responses are good. And if the responses are good, you'll get your drug approved. If the responses are not good, then you are still taking them to a phase 3 in the hope of getting a positive phase 3. So as I mentioned, these single arm trials are deceptive, even for the responses. Even if the single arm trial shows that the responses are like 40% and duration of response is 8 months, when you do a randomized trial for the same drug, you'll see that the responses have fallen. And this is probably due to regression to the mean, or most importantly, patients in phase 2 are very highly selected patients. So this is an example of duration of response for targeted drugs from single arm trial versus randomized trials. And we saw that the duration of response in a single arm trial is 17% higher on average than the duration of response in randomized trials. And except for one case, almost in all other cases, the duration of response was higher in single arm trial compared to the randomized counterpart. So a similar study done for response rate several years ago. This is for cytotoxic chemotherapy drugs. And they saw that for the vast majority of cases, the response rate in phase 2 is higher than the response rate for the same drug in the same setting than the response rate in phase 3. And the difference is almost 13%. So the take-home message is response rate and duration of response that you see in single arm trial is probably falsely high. The true response and duration is probably less than what you see in single arm trials. And randomized trial gives the actual answer to the question of what happens if I don't do this treatment, if I don't do this intervention. And the results from single arm trials are biased. They are actually not even meant to inform practice. What about randomized phase 2? Because you will see this more often nowadays. Usually when we say phase 2, this is a single arm phase 2, but nowadays people are coming up and doing more and more randomized phase 2. Randomized phase 2, I would argue that it is actually an improvement over single arm phase 2. Randomized phase 2 is better than single arm phase 2. But again, randomized phase 2 is not meant to replace randomized phase 3 trial. Randomized phase 2 is better than single arm phase 2 because it provides a better screening of phase 2. Even as of now, 40% of our cancer drug trials fail at phase 3. So we need to improve that percentage. And doing a randomized phase 2 is better than a single arm phase 2. For that purpose, it removes the selection bias that I said happens in single arm trial. You cannot select very fit patients for the drug arm only because you are randomly allocating patients to intervention or the control arm. And this will help us to screen out ineffective drugs. And the single arm phase 2 is for screening out ineffective drugs, but randomized phase 2 will help us to screen in potentially effective drugs. This is obviously beyond the scope of our small talk today, but if you want to learn more about randomized phase 2 design, these are the 2 articles that I would recommend. And this study actually shows that why we should not rely on randomized phase 2. Although it is randomized, we should be doing phase 3 and not rely totally on randomized phase 2, because as this study shows that the treatment effects are falsely exaggerated in phase 2. Although it is randomized, if you see the hazard ratios, then it shows more benefit in randomized phase 2 than what you see in phase 3. PFS benefit was 26% larger in phase 2. Overall survival benefit was 27% larger in phase 2. So randomized phase 2 results, again, are not meant to inform practice. They are meant to support phase 3. But a randomized phase 2 is better than a single arm phase 2. And one newer complexity that you'll see in more and more trials. Usually when we see randomized trials, there is 1:1 allocation. That means if there are 500 patients in the trial, 250 get the new drug and 250 get the standard of care. But nowadays, you see some of these trials do 2:1 randomization. So that means if there are 300 patients in the trial, instead of 150, they're allocating 200 patients to the new drug and 100 patients to the control arm. But this is called unequal randomization. 2:1, someone might do 3:1 randomization. But there is a case to be made against such unequal randomization, because we know that for this unequal randomization, you actually need more sample size than what you would need for equal randomization. So your trial gets longer, your results take a longer time to be completed, and it requires substantially more resources, because a 2:1 requires 12% more patients than 1:1. A 3:1 randomization requires 33% more patients than 1:1. So these are not efficient methods. And obviously, if you want to stay with the same sample size, then you are losing power. If you are increasing the sample size, then you need more resources. The trial becomes more expensive. And the other point is you're actually exposing more patients to unproven intervention, because instead of doing 150 for a 300 patients trial, now you're doing 200 and 100. So you are allocating more patients to the newer drug, but that newer drug has not been established yet. So you are exposing more patients to unproven intervention. What if the new drug has more toxicities? What if the new drug has actually more fatal adverse events? What if more people die with the new drug? Then you are actually exposing more patients to an unproven intervention, and that is harmful. And some people argue that 2:1 is important because it helps to recruit patients early, because more patients feel like they can get to the drug arm, and we believe that the drug is beneficial. But that's not a sound argument, because it violates the principle of clinical equipoise. Clinical equipoise means there is enough reasons to believe that we do not know which treatment is better, and therefore we are doing a trial. If you already know that the newer drug is better, why are you even doing the trial if you already know the answer to the question? The very fact that you are doing a clinical trial means that you do not know the answer to the question. So if we are doing 2:1 randomization, saying that we want more patients to get the drug, then that means there is no clinical equipoise. And then there is the problem of validity, because one of the beauties of blinded randomized trial is we do not know what the patient is getting. So we are blind to the intervention. So we are not biased in our assessments. But if we know that there is 2:1 or 3:1 randomization, then we know that our patients are more likely to be getting the drug than the control arm. And people argue that patients are more willing to participate in trial if there is 2:1, 3:1 randomization, because they believe that they will get the newer drug. But actually, there is no evidence to that. There is no evidence that using unequal randomization improves recruitment. Again, this is a complex topic. If you want to learn more about it, I would recommend this article that I have put here. You can just Google this, and that's a beautiful article that explains more about the issues with unequal randomization. And okay, we talked about randomization versus single arm trials. We talked about randomized phase 2. We talked about 2:1, 3:1 randomization. What is the next thing that we need to look for? The other thing is we need to check what are the patients that are being enrolled in these trials. Are the patients in these trials representative of our routine patient population? In other words, if you are a patient, are you being represented in the trial? Are there people like you in the trial? So actually, cancer drug trials are getting very complex. The average number of eligibility criteria is 16, and 60% of them are related to comorbidities. So we are excluding many patients. We are including only very selected patients, and there have been some efforts to that end to rectify that. And ASCO and FDA, they had worked on a recommendation, and one of their recommendation is that patients with stable brain metastasis, they should not be routinely excluded from the clinical trials. And they also address the age barrier. Patients who are more than 12 years of age, they should be included, unless there are reasons to believe that patients between 12 to 18, maybe they behave differently than older patients in terms of tumor biology. But unless you have such a strong rationale, you should not necessarily exclude patients who are more than 12 years of age. They do not talk about the upper age boundary here, but yeah, there should be no reason to exclude anyone just based on the age. And then they talk about excluding patients with HIV/AIDS if it is under control. There is no reason to exclude them from the clinical trials. They should be included. And then about the renal function criteria, I would have argued for hemoglobin, other blood parameters, and liver function test as well, but they talk specifically about the creatinine clearance here. Unless the newer drug is getting excreted by the kidneys, we should not exclude these patients regularly. So this is a step in the positive direction. There is no reason to exclude patients like these from clinical trials, because these are the patients that we see every day in the clinics. These are the representative patients. What is the point in knowing whether a drug works or not in a patient who has pristine renal function, pristine liver function, pristine bone marrow, does not have any brain metastasis, and fits all these criteria, and then having patients who have poor renal function, who have brain metastasis and all these problems in the routine clinic. So our clinical trials need to be more and more relaxed in terms of eligibility criteria. But this is one thing to look out for when you're reading a clinical trial. What are the inclusion criteria? What are the exclusion criteria? And are patients like me being represented? I was a part of this research that looked at patients who are involved in clinical trials in the US, and we compared that with what we see in the SEER database for patients with cancer. And we found that female patients are underrepresented, 36% in clinical trials versus 49.6% based on the SEER database. And Black patients were underrepresented, only 2.1% in the clinical trials versus almost 10% in the routine database. And patients with hepatitis infections were also underrepresented. So we concluded that Black patients, women, and patients with brain metastasis and hepatitis infections were underrepresented in the US clinical trials. And why does it matter? Why should we try to see that more and more patients are like routine patients instead of highly selected patients? That is because there will be severe exaggeration of benefit in these clinical trials. And in our routine world, when we are using these drugs in the routine patients, there is huge shrinkage of clinical benefit. I wrote this paper for hepatocellular cancer, but the lessons remain the same. So in hepatocellular cancer, if you look here, the first two drugs, you look at the median OS from the drugs, and this is 10 months and 13.6 months. Hepatocellular cancer is a cancer that is quite lethal. And at that time, when these drugs when sorafenib was being tested, I think the median survival was only 6 months. But here you can see that even control arm patients have a median survival of 8 months. So these are highly selected patients. But interestingly, if you look at this second line trial, so these are patients who have already failed on first line. So you would expect their survival to be still poorer. But even patients in the second line, even in the control arm, we are seeing survival of 8 months, 7 months, 8 months. So this clearly shows that these are highly selected patients in these trials. And if we look at the sorafenib trial in particular, as I mentioned, this is 11 months survival with sorafenib versus 8 months with placebo. So this is 8 months with placebo. But in the real world, when they looked at what happened, they saw that 60 days, this is 2 months plus 3 months. So in the real world, patients who got the drug had a median survival of 5 months. only 5 months with sorafenib. So just to highlight this, in the trial, placebo arm patients had a median survival of 8 months. In the real world, patients who got the drug had a median survival of 5 months, which is 3 months less than what placebo arm patients had in the trial. Okay, so we talked about the representativeness of the patient population. The next question to ask is, what is the control arm patients getting? Is the control arm treatment appropriate? Because these clinical trials can be gamed by using a substandard control arm. So what do I mean by that? There are 3 ways of doing that. One is using a control arm treatment that has already been proven to be inferior in previous randomized trials. We know that this drug is inferior, but we are still using that as the control arm treatment. The second is saying we are allowing treatment of physician choice for the control arm, but then excluding certain beneficial treatments. And third is when we are using a placebo or an ineffective drug instead of an active comparator. I'll give you some examples. And again, if you want to read in detail, we discuss about these issues in this Lancet paper. I'll give you one example. This is from lung cancer. Pembrolizumab was a PD-1 inhibitor, was an immunotherapy that was approved for lung cancer in 2016. In 2016 October, this drug was approved, not because it improved only PFS, but also because it improved OS, and not by a small margin. This was a substantial improvement. This was a real good improvement. So any patient who had PD-L1 of at least 50% and lung cancer, after 2016 October, they would receive pembrolizumab if access to this drug was not an issue. But then they're in a trial of cemiplimab. Cemiplimab is a me-too, another version of immunotherapy. It's a me-too pembrolizumab. It's like pembrolizumab. And obviously, we already know that pembrolizumab is beneficial. But when they ran this trial for cemiplimab, they used a control arm of chemotherapy. So what I'm trying to say here is these patients would have received pembrolizumab, which is better than chemotherapy, if they were not a part of this cemiplimab trial. But because they were a part of the cemiplimab trial, patients who got randomized to the control arm received chemotherapy, which we already know is inferior to pembrolizumab. And this drug, the cemiplimab trial, it ran from 2017 June to 2020 February. It ran outside of North America, but then these results helped the drug to get approved by the FDA in USA. So that's an example of using a control arm treatment that we have already shown to be inferior in a previous trial. The other example is not allowing an effective drug to be used by saying treatment of physician choice. This is the olaparib trial in metastatic breast cancer. And again, there is 2:1 ratio that we discussed before, but they say that they randomize patients to receive olaparib or standard therapy with single agent chemotherapy of the physician's choice. They say this is physician's choice. Physician can choose the chemo for the control arm, but they mention it's only between capecitabine, eribulin, or vinorelbine. That means you cannot choose anything beyond that. For patients with BRCA mutation positive breast cancer, several physicians would actually might have wanted to use carboplatin because there is evidence to show that platinum chemotherapy is more beneficial in patients with BRCA mutation positive tumors. But by saying that you can choose between capecitabine, eribulin, or vinorelbine, basically what they're saying is you cannot choose carboplatin. And the other example is that of using a placebo or ineffective control instead of an active control. This is for metastatic pancreatic cancer. What we do here is usually we give patients FOLFIRINOX chemotherapy. And this is also a very lethal cancer. So as long as the patient is tolerating the treatment and the drug is effective, we don't stop it. But in this trial, what they did was they gave FOLFIRINOX chemotherapy to patients for 4 months, and then they abruptly stopped the treatment, even if it was working for the patient. even if patients were not having side effects. They just stopped it and then randomized patients to receive olaparib or placebo. Again, this placebo arm makes no sense because in the real world, these are the patients who would have continued on chemotherapy and not just stopped the treatment. And then they saw that there was benefit in PFS, but no benefit in OS. And the quality of life did not improve, which we'll talk about later. But this is just to give you an example of the different scenarios in which we can game the control arm to show that our drug is better than it actually is. So after you have asked the question of, am I being represented in this trial? Are people like me being represented in this trial? The second question you need to ask is this control arm actually the treatment that I would get if I was not a part of this trial? So that's the question you should ask. If I'm not a part of this trial, what is the treatment that I would routinely get? What is the treatment that people routinely get if they are not a part of this trial? And if that treatment is not the control arm of the trial, then that trial is not in your best interest and you should avoid those trials. So this is the problem. Who will control the control arm? We have written several papers about it. The first paper that I wrote in Nature Reviews Clinical Oncology, that's for the lung cancer trials, including the trial that I just showed. There are several trials ongoing even today for immunotherapy that are using chemotherapy control arm. Nobody uses chemotherapy control as long as access is not a problem. And then in prostate cancer, we saw that people are continuing to use an ineffective drug that has already failed before as the control arm treatment. So this problem is rampant in every cancer type. The other issue to look for is post-progression therapy. What that means is, what treatments are the patients getting after the patients progress on this trial? So what is the treatment that they get after they progress? And is it uniform in the intervention arm and the control arm? Just one example from the Mona Lisa trial of ribociclib in first-line hormone-positive breast cancer. Now, overall survival was the key endpoint, and post-progression therapy affects overall survival assessment. They showed that overall survival improved with the use of ribociclib. But if you look at post-progression therapy in this table, you see that it's like 70%, 68.9% in the ribociclib arm and 70% in the placebo arm. They got any medication. This is not just any specific, but any medication. That means almost 30% of the patients, or at least more than 25% of the patients, did not get any treatment. Now, just think about this. This is first-line hormone-positive breast cancer. We have several treatments. We have several hormonal agents. We have several chemotherapies. We have several drugs in metastatic breast cancer. For a patient who has hormone-positive metastatic breast cancer, I think we'll have 7, 8, 9 lines of treatment. But here it shows that almost 30% of the patients got just one line of treatment, only one line of treatment, and did not get any treatment after progressing on first line. You have 4 or 5 different hormonal agents that you can use. You have 3 or 4 different chemotherapy agents that you can use. But more than 30% of the patients, they did not get anything at all, only the first line of treatment. What that means is the OS benefit that we are seeing here is probably from that, because this is more like patients in the drug arm, they got exposed to 2 different treatments, and patients in the control arm, they got exposed to just one treatment. So is it really the beneficial effect of ribociclib on overall survival, or is it because these patients are being deprived of any treatment in further lines? That's an important question to be asked. And especially if you look at the subgroup analysis, you see that most of the benefit is being derived from the Asia subgroup. Here, the hazard ratio is 0.3. If you look at Europe and Australia and North America, these two are actually touching the line of unity. That means their hazard ratio is not significant. It goes to more than 1. So one could argue, and this is just hypothesis, we have not seen the data, they have not shown us the data, But this is just a hypothesis that probably patients in North America, Europe, and Australia, they did not benefit in terms of overall survival because they received multiple lines of treatment after progressing on this trial. And patients in Asia are showing so much of substantial benefit because they probably did not get any therapy after the progression of first line of treatment. It is plausible. Okay, next, after seeing about the control arm and after looking at what the post-progression treatment people are getting, the other question to ask is what's the primary endpoint of the trial? And the thing to remember here is how long we can live and how better we can live. These are measured by overall survival and quality of life. So these are the clinical endpoints. Anything else are surrogate endpoints like response rate, progression-free survival, disease-free survival, and so on. These are supposed to stand in for survival and quality of life. These are supposed to predict survival and quality of life. These are not clinical endpoints in themselves. The reason we use these surrogates are because they shorten the trial duration compared to using overall survival. Using progression-free survival shortens the time by almost a year. And response rate shortens the time by almost 19 months. However, not all surrogates are good surrogates. FDA says that the surrogate endpoints need to undergo testing to show that they can be relied upon to predict clinical benefit, and these are called validated surrogate endpoints. But the problem is almost 90% in 90% of the situations, the surrogate endpoints that we have are not validated. They are poor surrogate endpoints, especially in metastatic setting. Most of the surrogate endpoints that we are using have very low correlation, and same is true in other situations as well. There are very few instances where you can confidently say that this is a validated surrogate endpoint. That is for overall survival. Sometimes people argue that, okay, if delaying progression, okay, it may not improve survival, but it should improve quality of life, right? If your progression is delayed, then you will probably feel better for a longer time. That's a reasonable hypothesis, and which we tried to test in 2018. But when we tested, we found that there was very poor association between improving PFS and improving quality of life. There was almost no correlation, very, very weak correlation. And that is probably understandable because the way we define progression is any tumor growth beyond 20%. And probably there is not necessarily any quality of life difference when a tumor size has increased by 18% versus 21%. And in fact, in one of our recent papers, we looked at the quality of life outcomes and survival outcomes. And as you can see in this table, the reassuring thing is of the drugs that improved overall survival, zero, none of them worsened quality of life. So that means if a drug has improved survival, you can be confident that it will not worsen your quality of life. It may improve, it may not improve, it may remain the same, but it will not worsen. The quality of life of a drug that has improved OS has not worsened. But you cannot say the same about progression-free survival. Here you can see that there were 4 instances in which the drug improved PFS but worsened quality of life. Among the 6 trials that showed worse quality of life, 4 of them in fact improved progression-free survival. So progression-free survival is a very bad surrogate here. And just by seeing that the PFS has improved, you cannot say that the quality of life will improve. In fact, it can even worsen. And that's why we need to differentiate between validated surrogate endpoints versus non-validated putative surrogate measures. For breast cancer, because this is a breast cancer group, just to give you an idea, pathological complete response, it does not correlate with survival. Again, there is a difference between prognostic and prognostic marker and surrogate marker. Patients who have pathological complete response, they do better than patients who don't have pathological complete response. But a drug that improves PCR rate does not improve overall survival. Disease-free survival, it's not, again, correlated with OS overall, but among HER2 positive subgroup of patients, we see a strong correlation. Response rate, not correlated. PFS, only mild to moderate correlation, not sufficient. For event-free survival, there is some correlation, moderate correlation. And the next thing is now to look at the results itself and to see how significant the results are. This is a cartoon showing scientists worshipping at the altar of p-value less than 0.05. A p-value of less than 0.05 is what we classically consider to be statistically significant. But statistical significance and clinical meaningfulness are something different. Statistical significance tells you how likely the results are to be true, but it does not tell you how good the results are. And I have given some examples in this paper from breast cancer. Among these two examples, one example I'll highlight to tell you what the difference is between statistical significance versus clinical benefit. This is the phase 3 NALA trial of neratinib in metastatic HER2-positive breast cancer. You can see here that the median PFS with the use of neratinib was 5.6 months versus the control PFS of 5.5 months. 5.6 versus 5.5. That's a difference of 0.1 month of PFS. Not even OS, 0.1 month of PFS. That is 3 days. 0.1 month is 3 days. Those 3 days can simply be because there is a difference in scheduling for taking CT scans of 3 days. But the p-value, if you look at the p-value, this is less than 0.05, it is 0.0059. So yes, it is statistically significant. The conclusion of this trial is this drug significantly improves PFS. But if you look at how much PFS, it's only 3 days, which is not at all meaningful. So that's the difference between statistical significance and clinical benefit. The other question sometimes people ask is, oh, is PFS a valid surrogate here? But I think that question does not even need to be asked. That's such a small PFS benefit. You don't even need to care for OS here. But if you do, then OS, of course, did not improve. But this is how they concluded, by the way. They said, although a numerical difference favoring neratinib was observed for OS, statistical significance was not reached because their OS was negative. But they did not want to say OS did not improve. They said there was a numerical difference. Okay, some other issues. Now, these are some, these things will take a lot of time, but just to make you aware about some of the issues related to critical appraisal. One is the non-inferiority trials. So far, what we have talked are about superiority trials, but there is a separate variety of trials called non-inferiority trial. And then there is the issue of early stopping of trial, censoring, and subgroup analysis. We'll not have time to discuss these in detail. I'll try to just touch into some of the things. Non-inferiority trials are different because they are trying to test whether or not the newer intervention is not worse than what we already have, instead of testing whether it is better than what we already have. And this is justified if the newer intervention is less burdensome, less expensive, less toxic, or improves quality of life. But the problem is we have seen that, sorry, let me go here. Sorry, I think I missed that slide. Okay, but we have seen that in several cases, the non-inferiority design is not justified. The newer drug is in fact more burdensome, more expensive, more toxic. It does not improve quality of life, but still people are doing non-inferiority design trial because they can get their drug approved. Because what to call as non-inferior is quite subjective, and they use a very lenient margin. By that I mean, if you say, okay, if the mortality increases by 50%, we'll consider it non-inferior, then any drug can become non-inferior because you are defining it in such a way that it's very difficult to fail. So that's why if you are participating in a non-inferiority trial, you should ask whether it is justified, why non-inferiority design, and second, what is the definition for non-inferiority. And the other thing I mentioned was trials that are stopped early. Sometimes you can see that this trial was stopped early for futility. That means the trial was not going to be successful, so we stopped it early. That's fine. But sometimes you'll say that the trial was stopped early because we saw signal of benefit and we did not feel comfortable randomizing patients to the control arm. That is fine, but studies have shown that these trials that are stopped early for benefit, they exaggerate the benefit, because by definition, in order to stop early, the drug has to show very impressive results. With maturity, that result might flatten out, but when it is stopped, the results will look very impressive. So if it is a trial that was stopped early, we should just remember that probably the benefit is not as impressive as it has shown. The benefit will be there, but the magnitude may be smaller. And censoring is a very difficult topic to cover today in a few minutes. So I'll leave the censoring part here and move on to the quality of life publication bias. Quality of life is an important metric to make treatment decisions, but you'll find that several of these trials do not provide quality of life information because either they don't include quality of life as an endpoint, or even if they include, they do not report on quality of life outcomes. So in this study, we found that more than 125,000 patients' quality of life information was missing. And sometimes you'll find that they publish quality of life information, but with a substantial delay, like 2 years, 3 years after the results are published. And that's an issue that we can only advocate for, but to keep in mind, especially if you are participating in a clinical trial, if you know some patients who are participating in a clinical trial, maybe they can ask the trialist about what is your plan to publish quality of life information, so that we can give an indirect push and advocacy for this to change. And the other thing when you're reading a trial report is about harms. Because again, if you're reading the abstract, this appears most frequently. Instead of saying what the side effects are and what percentage of the patients are facing side effects, they will just say that the side effects profile was acceptable. The side effects were manageable. And the side effects were well tolerable. These are false, these are downplaying terms. These are terms being used to mislead the readers. Acceptable to whom? Like, nobody has asked the patients whether grade 3 diarrhea is acceptable to them or not. The most disappointing for me was I saw that the trials were saying the side effects were manageable, but then I went in to read the report and there was a number of patients who had suffered fatal adverse event. Fatal means the patients died from the side effects, not from the cancer, but from the side effects. Then by definition, the side effects are not manageable. If it was manageable, they would not have died. But still they were writing in the abstract that the side effects were manageable. And this is probably the final point for today about subgroup analysis. Sometimes what you will see is the overall results are negative, but they will say in one subgroup, the results are positive. You should always take that with a grain of salt. You should first ask whether that subgroup was pre-planned or post hoc, and whether it was controlled for subgroup multiple analysis. For example, this is the affinity trial of pertuzumab in early breast cancer adjuvant trial. Overall, if you look, there is like statistically, you'll see that it is just less than 0.05. But if you look at the graphs, it's hard to say that there are 2 lines there. There is so small benefit, if any. But instead, what they tried to highlight was, we looked at node negative and node positive patients separately. And for the node positive patients, there is a good difference. So this drug should be used in node positive patients. But if you look at the p-value for interaction, it is 0.17. This shows that this difference between subgroups is not significant. But this is how they promoted it. For node positive patients, we should use this drug. And they showed the graph for node positive patients, and they showed that it's a little wider than the overall patient population. So we should be using in node positive patients. This is just trying to fool by using subgroup analysis. One more example from the atezolizumab trial that I showed first in my first slide. Here in the trial protocol, they said that if the overall survival was positive in the intention to treat in the total population, then they would run overall survival in the PDL1 population. But in the total population, p-value was not less than 0.05, it was 0.08. So it was not positive. But then they wanted to salvage the result after the trial was negative. And they, against their own statistical protocol, they still did a subgroup analysis in the PDL1 positive subgroup, and they claimed that there was a benefit. However, this was completely false positive, and we wrote about this in this paper. And the NBCC also wrote about this trial and asked the patients to be cautious in their newsletter. And ultimately, this drug is now revoked by the FDA. So this is just a summary of the points that I discussed today. So what should you look out for when reading a clinical trial report? First, look at the conflicts of interest. Abstract, don't read the abstract. Look at who wrote the paper. Then look whether it's a randomized trial or a single arm trial. Even in randomized trial, whether it's a phase 3 randomized trial or a phase 2 randomized trial. What is the randomization allocation ratio, 2:1, 3:1, or 1:1? What is the eligibility criteria? Is the trial population representative? Is the control arm actually getting the standard of care? Did the control arm get crossover, or like what is the post-protocol therapies they got? What was the primary endpoint of the trial? And was it statistically significant? And was it clinically meaningful? And then we discuss some niche topics like non-inferiority trials and subgroup analysis. One of the readers of my paper made this cartoon and sent it to me. So, this is just a cartoon to show that poor control arm, poor surrogates, inappropriate crossover, non-inferiority margins. These are things that should be a red flag signal versus OS endpoint and appropriate study design and so on. So, I think these are points that we should be very careful about, and we need to train ourselves to start seeing these things. And just a little, self-promotion that I have a YouTube channel, and I try to keep all my lectures into my YouTube channel so that anyone can watch these and learn from these. This is the link to my YouTube channel, or you can just go to YouTube and search for my name. And there is a playlist called Talks by Me. There might be other playlists that may not be of interest to you, but if you go through this playlist, then I think you'll find several other topics of interest. I think even my last, from January 2020, one of my NBCC seminars, I have also put it on the YouTube channel, and I'll be putting this talk as well. So thank you. I'm happy to take questions.
Thank you, Bishal. That was an excellent presentation and lots of good tips. Again, if anybody has questions, feel free to submit them through the Q&A. I know we probably have limited time, or raise your hand if you'd like to ask a question directly. I guess, Bishal, one of the things that I continually be stunned by are the subpar control arms. And I'm just, as an advocate, somebody who's not trained in medicine, how would you recommend advocates even spot that? How would you approach looking to confirm that drug in the control arm is acceptable?
As a potential participant, or if you're a patient and wanting to get enrolled in the trial, I think the best question to ask for the trialist or for a physician is, what is the treatment that I would get if I'm not a part of this trial? And if they mention drug X, and that drug X is not the control arm of the trial that is being offered to you, then that's a red flag signal. You should not participate in those trials, because that clearly means that they're depriving the control arm patients from the best possible treatment that's already out there. But as a reader of the trial, if you are reading a trial, then in that situation, as a non-physician, it might be difficult to say whether the control arm that is being offered is the right control arm or not. But in that case, I think one way to look at that is whether or not there are other options available for the same disease condition that are already approved in the past. And if that's the case, then one needs to question why that option is not included as the control arm. And in some situations, it becomes especially tricky when placebo is the control arm, because there are some situations where placebo is appropriately control arm, and there are some situations where placebo is inappropriately the control arm. So even in that situation, one needs to ask, is the default here not to do anything? If the default is not to do anything, then probably placebo is appropriate. But otherwise, why are the control arm patients not getting any active treatment? And similarly, sometimes what we see is the control arm patients are getting the treatment that they have already progressed on. For example, these patients progressed on a taxane, maybe a different taxane, but the control arm is getting taxane again, which makes no sense. We would never do that in clinical practice. In prostate cancer, that happens all the time. We have seen several trials where patients who have progressed on abiraterone continue to get abiraterone as the control arm treatment. So these are some of the potential pointers to identify these issues.
Right. So Helen Schiff has a question. Feel free to ask it out loud, Helen. I've unmuted or allowed you to unmute.
I'm unmuted?
Yeah.
Okay. Well, so my question is, how can the NBCC have more influence on clinical trial design? Should we participate in ODAC and in the FDA more? I mean, the drug companies don't really invite us to a lot of, they used to, but they don't want us because we're too critical of their designs. But how can we have an influence?
That might be a question for Michelle, but yeah, I think there is a huge role for patient advocacy to get a front seat in these policymaking decisions, because if patient advocacy groups like NBCC do not become active and try to get the front seat in these policy decisions, then this seat will be taken by other people with financial stakes in the game, or other people with biases, and there is also be detrimental for all of us. So what are the ways to try to get a seat at the ODAC panel, at the FDA panels for making these decisions, or even these cancer clinical trial groups? I know that several clinical trial groups nowadays have patient representatives as a mandate, as a mandatory requirement in the clinical trial designs. I think we should try to, people who are appropriately cautious about these things and are knowledgeable about these things and want to bring a change, I think we should try to be more active and participate in these panels.
Am I still on?
Oh, go ahead, Helen.
Well, I was saying, besides participating in ODAC, most of those hearings allow patients to testify. So that's another thing. I mean, we could line up a lot, and we've done that in the past, like for Avastin. Several of us oppose the approval of Avastin.
Yeah, one of the
news coverage. It's a good place to get news coverage and to kind of unmask what the drug companies are doing.
One of the best things that I have personally seen was in one of the ASCO FDA session, one of the ASCO sessions that involved the FDA, and after the speakers spoke, there was a patient representative in the Q&A session taking the mic and telling the FDA that the PFS was not enough for them, for the patients, which was an interesting sight to behold, because it usually is the other way around, where the FDA tells everyone that PFS or surrogate endpoints should not be used unless they are validated. But here, the patient community was, or a patient representative was telling the FDA about the surrogate endpoints and why it's not enough for them. So I think, yeah, those are the small actions that we can take whenever we are in any meetings or any seminars.
But they did a study saying that patients do think that progression, free survival is valid. But I don't know, we never found, we should actually find out,
Yeah, exactly how that
involves.
assessment was done. And I think there are probably far more patients out there who are vocally for a lot of the drugs that are being marketed and progression-free survival. But this is where education comes in, and which is why we try to make sure that advocates understand these issues.
Yeah, because I would guess that many patients do not even understand what PFS actually means, because it's not a term that we use every day in the clinic, and because it has the term survival attached to it. I think many patients, even some physicians, they actually do not understand what actually PFS means. So these surveys should start with a proper education of what these endpoints mean.
Now that drugs are so much more expensive, they might be more concerned about
Yeah.
Right, right.
We, for what it's worth, we are actually running a study here in Canada, asking the patients about PFS, their impression of PFS, and like what magnitude of PFS benefit would be sufficient for them in exchange of the given side effects.
Right, right. So we do have a couple of other questions, and frankly, I'm looking forward to seeing the results of that study. But there was a question: what might be the value of PROs, patient-reported outcomes, in side effects and quality of life elements of trials?
Absolutely.
Are you seeing more and more PROs being incorporated, and is there a good place? I would imagine a good place for those.
Yeah, so this is a positive sign that we have seen in more and more trials nowadays. They are incorporating patient-reported outcomes more nowadays than we used to see in the past. And there are some like institutions that are taking a stronger stance on this. For example, ESMO magnitude of clinical benefit scale, and I think Nathan Cerny is going to talk with this audience in the future. He might mention more about this. To provide a grading for the magnitude of clinical benefit scale, there is one key component of quality of life. And now we are coming up with a checklist about how quality of life and patient-reported outcomes should be reported to be eligible to get that upgrade for the MCBC scores. And similarly, there are other institutions like the CISACOL initiative and the Consort Pro initiative that are providing recommendations on how to properly conduct and report quality of life outcomes and patient-reported outcomes from cancer drug trials. I think that, I think 5 years from now, it would be very difficult for a cancer drug, a new cancer drug, to not report patient-reported outcomes and still be considered to be a good therapeutic option. I think in this particular field, the change is slowly happening.
Right, right. I'll just ask one more question, and I guess this is more from your, it goes back to the control arm issue, and we've actually had a couple of webinars around IRBs and how really driven by this question of how can trials like that be approved. But the question is, do you think that IRBs are and the members of IRBs are trained to really, look for the red flags in clinical trials, like the different red flags that you've seen, that you've described to us today?
Yeah, that's a problem. No, I'd say that IRB members are not necessarily trained in spotting this. We have seen that, several times. Whenever I give these talks, people ask, like, why did these trials even pass the IRB? Because the members of the IRB, they are volunteer members, and they have their own constraints, I guess, to stay up to date about the literature in every possible topic. And these treatments are getting so and so complex that one has to actually devote substantial amount of time to stay current on what the standard control arm should be. So yeah, I think that's a problem. Even peer reviewers and editors of the specialty journals don't spot these things. So IRB is a problem, and I think we need to think about the IRB process itself, about who becomes the members of the IRB team, and if there is a certain trial that is being discussed in that IRB discussion, whether or not some external experts on that same trial without financial conflict should become a part of that IRB. So that's a very interesting question. That is very important question. I do not have like immediate solution to offer, but this is something that we should all be careful about.
Well, in the interest of the time that you've already given to us, I just want to thank you so much for coming back and doing another webinar for us and helping to share your knowledge with our advocates. And, we want to be that voice out there. And so we appreciate your time and sharing your expertise and pushing for doing the research that you do. I will tell you, we follow your research very closely.
Thank you very much.
Very pleased to have you here today. And I thank everybody who participated. And we'll be, as I think Vishal noted, we're going to be bringing Dr. Nathan Cherney in to talk with us at some point, hopefully before the end of the year, on the magnitude of clinical benefit scale. So that should be an interesting webinar. But in any case, I will let you go. And it was a pleasure having you today. So thank you so much. And thank you everyone for joining us.
Thank you. Thank NBCC and thank you all the audience. Honestly, patients and patient advocates are the motivation for what I do. So yeah, thank you. I exist because you exist.
All right. Thank you. Goodbye,
Bye.
everybody.